Let's talk about hereditary breast and ovarian cancer syndrome. Background: BRCA account for 20% of epithelial cancer and 5% of breast cancer. BRCA1 is on chromosome 17, 2 is on 213. General population, 1 out of 500. Carrier rate: Ashkenazi Jews, 1 out of 40. 70% cumulative risk of breast cancer for both mutations. BRCA1 is more likely to be hormone negative. BRCA2 is more likely to be hormone positive. For ovarian cancer, BRCA1 has 40% chance and BRCA2 has 20% chance. 140 to 20. They're more likely to be high-grade serous or endometrioid and not likely to be mucinous or borderline. Other cancers: BRCA2 has 10% risk of pancreatic cancer and possible uterine cancer risk. Other gene mutations: P10 is a Cowden syndrome, increased risk for breast cancer. TP53, increased risk for breast cancer. Lynch syndrome, colon cancer, uterine but not breast. Clinical consideration and recommendations for genetic counseling. If the patient has a personal history or family history of breast or ovarian cancer, or if the patient has a ovarian epithelial cancer, genetic counseling is advised. So box 1 for the complete criteria. Let's get to it real quick. So for genetic assessment, breast cancer. For genetic counseling, okay, let's take a look. Yay. Okay, there we go. So criteria for further genetic evaluation: women affected with one or more of the following: should receive genetic counseling and be offered genetic testing. So epithelial, ovarian, tubal or peritoneal cancer, breast cancer at age 45 or less, breast cancer and have a patient or have a close relative with breast cancer at age 50 or less, or close relative with epithelial, ovarian, tubal or peritoneal cancer at any age. So if they themselves have breast cancer of less than 45, If they have breast cancer and then they have their sister or mother has breast cancer at age 50 or less, or if they have ovarian cancer at any age, but they themselves have breast cancer already. If they have breast cancer at age 50 or less with a limited or unknown family history, breast cancer, and have two or more close relatives with breast cancer at any age. Breast cancer and have two or more close relatives with breast cancer at any age. Two or more at any age. One with breast cancer at 50. If they have breast cancer at 50 with no unknown family history, breast cancer, and have two or more close relatives with pancreatic cancer, two breast cancer primaries with the first diagnosed before 50, triple negative breast cancer at 60 years or less, breast cancer and Ashkenazi Jew, pancreatic cancer, and have two or more close relatives with breast cancer or ovarian cancer, or aggressive prostate cancer. So all these patients should receive counseling and testing. And then if the patient has no cancer, but one of the or more of the following but if they have one of these, if they have a close relatives that meet the criteria above, if they have a first degree relative that meet the criteria above, if a close relative carry known BRCA or BRCA2 mutation, or a close relative with male relative with breast cancer. Okay, close relatives is first degree, second degree, and third degree. Grandparents and cousins. Limited family history, fewer than two first degree or second degree female relatives beyond 45 years. So woman with no cancer, however, her sister had ovarian cancer or something. But one or more of the following have an increased likelihood of having an inherited predisposition of breast and ovarian, tubal, or peritoneal cancer, should receive genetic counseling and offer genetic testing. So the first degree relative that meets one or more of the above criteria. So if the patient has no cancer, but her sister had ovarian cancer, Okay, so let's see. Genetic assessment, pedigree, risk assessment, informed consent, post-testing counseling and interpretation, true positives, true negatives, uninformed, uninformative negatives with no pathological variant but strong family history or other family member with variant. Variant of undetermined significance. So for BRCA testing, there's BRCA mutation testing with targeted single site mutation if the family member already tested. Targeted multi-site for certain individuals. Multi-gene panel, high-risk individual when single site mutation is negative. BRCA patient risk reducing strategy for ovarian cancer. Screening with all transvaginal ultrasound and CA125 is not effective for to decrease mortality in high-risk individual. Can be used starting at age 30 before patient decides to have a BSO as a short-term surveillance. Annual transvaginal ultrasound and every 6 months CA125. Risk reducing agents, oral contraceptive up to 80% reduction in ovarian cancer in BRCA1, 60% reduction of ovarian cancer in BRCA2, no increased risk for breast cancer with OCP use. Surgical risk reduction, BSO should be considered at age 45 for, and also for these BRIP 1, RAD 51C and D. If patient has Lynch syndrome, BSO with hysterectomy is recommended. Recommended age for BSO. For BRCA1, 35 to 40. For BRCA2, 40 to 45. Risk of ovarian cancer is about 3% before 40. By 50 years old, the risk is 20% for BRCA1. Risk of breast cancer for BRCA2 is 30% by age 50. %80 reduction ovarian fallopian peritoneal cancer. Bilateral salpingectomy in average risk population, 60% reduction of ovarian cancer risk. In high risk population is currently under investigation, does not protect against breast cancer. BRCA patients risk reducing strategy for breast cancer. Screening starting at age 25, clinical breast exam every year, MRI with contrast annually due to increased accumulation radiation with mammogram at this age. At age 30, alternate between mammogram and MRI every 6 months. MRI has a higher false positive rate than mammo. Risk reducing agents. Breast cancer risk reduction 60% in BRCA2 with tamoxifen. No reduction in BRCA1 patients with tamoxifen. Tamoxifen has greater risk reduction than raloxifene. Common side effects, vasomotor symptoms, vaginal symptoms, increased risk for VTE and endometrial cancer 2 times. So 2 times increased risk for VTE and endometrial cancer. Aromatase inhibitor can be an alternative if not taking tamoxifen. Higher risk of bone loss, I think. Risk reducing surgery, bilateral mastectomy, 90% reduction depending on type of mastectomy. Contralateral prophylactic mastectomy is strongly recommended. 30% risk of contralateral recurrence in 10 years. 70% reported satisfaction with the decision to have mastectomy and decreased anxiety and concern after 15 years. Bilateral subinguinoprectomy, reduce breast cancer and BRCA2, but only if the patient is premenopausal. Technique of doing the BSO, inspection of the diaphragm, liver, omentum, bowel, paracolic gutter, and appendix, ovary, fallopian tubes, uterus, bladder, cul-de-sac. Biopsy of any abnormal area, pelvic washing, ovarian vessel is isolated and ligated 2 centimeters proximal to the end of the ovarian tissue. Ovary removed at the uterovarian ligament as close to the uterus as possible. If gross cancer is identified, surgical staging with lymphadenopathy and omentectomy can be performed at the time of the risk-reducing surgery or wait for final pathology before definitive surgery. Serial sectioning of the ovaries and fallopian tubes is done to check for occult cancer by the pathologist. Follow up if no breast cancer, we can offer hormone therapy. Risk of breast cancer is not increased after hormone therapy is started when the patient is less than 45 years old. Not recommended to use CA-125 to screen for peritoneal cancer.